I think we should go ahead and get started. I'd like to thank everyone for joining us today for our MyCares webinar with Dr. Kathryn Berry from the University of Maryland. She is an epidemiologist and a cancer researcher. And today she's going to talk to us about alcohol and cancer, the Surgeon General's report, what does it mean, and what's she finding in her own research. So welcome, Dr. Berry, and thanks so much for being here.
Thank you so much for having me. So I will go ahead and share my screen here. Okay. Can everyone see the slides? Looks okay?
Yes.
Great. So thank you so much again for having me. So I guess I'll start off by just introducing the U.S. Surgeon General report. So some of you may have heard that earlier this year, the U.S. Surgeon General called for cancer warning labels on alcoholic beverages, similar to what we have for tobacco products. So why is this the case? How did this come up? So the report, actually, I'd highly recommend you check out the report if you haven't seen it yet. You can easily just search it online. But essentially, there's been strong evidence that consuming alcohol increases the risk of developing at least 7 types of cancer, which are shown here. So you can see mouth, throat, esophagus, voice box, breast in women, liver, and colon and rectum, or colorectal cancer. And there's a lot of information about how alcohol can increase risk, so like in terms of the biology. So we know that alcohol breaks down into acetaldehyde, which is a metabolite that can bind to DNA and cause damage. And if there's damage to DNA, that can lead to cells growing out of control and can lead to cancer. There's also a pathway that alcohol can generate reactive oxygen species, which can lead to inflammation and has also downstream effects that can lead to cancer of different types. And then there's a couple other hypotheses or some data on other ways that alcohol can cause cancer. So alcohol can affect hormone levels, and so it's thought that can be one way that it is linked with hormone-related cancer, such as breast cancer. And then another more information from the report says that if you're drinking alcohol, carcinogens from other sources, for example, from tobacco smoke, can dissolve in alcohol and making it easier for them to be absorbed into the body. So I think the primary two mechanisms are the first two here that have the most amount of information, but we have these other hypotheses and some information to support other mechanisms as well. So this is a chart or graph from the report. And so the question is, what is the risk that we see with alcohol? What is the risk of cancer? So this graph shows that as you have higher alcohol consumption, there's higher alcohol-related cancer risk. So this is referring to the 7 different cancer types that I mentioned earlier that have been linked with alcohol. And you can see that as women, so women are shown in the left graphs and men are on the right. And as people increase the number of drinks per week, their risk of cancer of these 7 types will increase. And it's thought that about 5 more women out of 100 would develop cancer due to consumption of 2 drinks a day. And then about 3 more men out of 100 would develop cancer due to consumption of 2 drinks a day. So what about alcohol reduction or cessation? Can that help at all? So there is some evidence of lower risk for certain cancers, for example, the mouth and esophagus, if you reduce your alcohol consumption or stop drinking. It's a little bit less clear what is that association for other types of cancer. And it's also unclear whether the risk returns to the level of never drinkers. So one of the interests of that I've had and some of my colleagues is specifically looking at alcohol and colorectal cancer. So a little bit of background on that is that there's been associations between recent alcohol drinking and higher risk of colorectal cancer. And by the way, I'll abbreviate colorectal cancer as CRC for the rest of the presentation. So we know that recent drinking is associated with higher risk of CRC, but there's limited research on the effect of lifetime drinking. There's also some inconsistencies about the effect by anatomic location. So there's different parts of the colon and the rectum that can be affected and whether the associations are the same across those different locations. There's also been relatively few previous studies that have looked at the chance of developing colorectal adenoma. And so an adenoma, if you're not familiar, is a type of growth or polyp in the colon or rectum that can progress to cancer. So this is considered a kind of precursor condition to colorectal cancer. So this leads into our current study that I'll talk a little bit about. So our group decided to look at lifetime average alcohol drinking and alcohol consumption patterns over adulthood in relation to the chance of developing colorectal adenoma, which are polyps, as I mentioned, and also the chance of developing CRC. We also wanted to ask if there's differences by sex. So do men and women, are there different associations for men and women? So we hypothesized that higher lifetime average alcohol drinking and chronic heavy drinking compared to lighter drinking over adulthood would be associated with a higher chance of colorectal adenoma and CRC. So this led us to our current study, which we conducted within one of the National Cancer Institute cohorts. It's called the Prostate, Lung, Colorectal, and Ovarian, or PLCO Cancer Screening Trial. This was a randomized controlled trial to test how effective different screening regimens are in reducing mortality from different cancer types. So the participants were enrolled back starting in the 1990s. They were ages 55 to 74 from 10 centers across the United States. And then half of the participants were randomized to receive screening, which for colorectal cancer, they were receiving flexible sigmoidoscopy. And this covers a part of the colon called the distal colon and the rectum. And then the other half of the participants were randomized to the control arm, which received usual care. And so participants who were in the screening arm received a sigmoidoscopy screen as part of the trial when at baseline or the start of the trial. And they also received a follow-up trial sigmoidoscopy after 3 or 5 years. And based on that, we were able to identify newly developed adenoma or polyp cases. So those were people that were negative on the first screen and positive on the second trial screen. And then we identified controls based on those who were negative on the baseline or the first screen and also negative on the follow-up screen. And then for our cancer analysis, so the cohort was linked with cancer incidence data, and we were able to identify over 1,600 cases over 20 years of follow-up. The follow-up has continued until the end of 2017 for cancer. So just to give you some background on what kind of information we had about alcohol intake. So participants completed a dietary history questionnaire or DHQ. They were asked, so this is something that they filled out when they started the study at baseline. They were asked about alcohol intake during 4 age periods, 18 to 24, 25 to 39, 40 to 54, and greater than or equal to 55 years, and also the year prior to DHQ completion, which was considered their current drinking. So then we computed a lifetime average alcohol intake based on a weighted average of these different age periods. And then based on that, we categorized people's patterns into whether they were never drinker, former, or current. And then among the current drinkers, we broke it down by their lifetime average drinks per week. So there was the lowest current drinking was from greater than 0 to less than 1 drink per week. The next group was 1 to less than 7 drinks per week. Then the moderate drinkers were 7 to less than 14, and then the highest drinking was greater than or equal to 14 drinks per week. We also categorized their lifetime drinking patterns using a combination of their drinking status, the past drinking frequency in those different age periods, and their current drinking frequency. And then we compared their pattern to whether they met the U.S. dietary guidelines. So currently, there's the dietary guidelines, which are separate for men and women. They suggest limiting alcoholic drinks to 1 drink per day or less for women and 2 drinks per day or less for men. So based on that, we were able to make a number of categories for their participants in terms of whether they were never drinkers, a former light drinker. So a light drinker meant that they fell below or that they met the dietary guidelines. And then we had moderate to heavy, current light, occasionally moderate current drinkers, occasionally heavy current drinkers, always moderate current drinkers, and always heavy current drinkers. So this way we can look at patterns of drinking over the course of their adulthood. So we did, for those who were interested in the statistical side of things, for our analyses of colorectal adenoma, we performed logistic regression to obtain odds ratios and 95% confidence intervals. We did separate models for lifetime average drinking and alcohol drinking patterns over adulthood. So the referent group or the comparison group was those who had low lifetime average drinking. So that was that lowest current drinking group. And then consistent light drinking was the referent group for our second analysis. And then we performed multinomial logistic regression to look at associations by advanced adenoma status or location of the adenoma. And based on using the sigmoidoscopy screening, we were able to look at the distal colon and the rectum. We could not look at the proximal colon, as that would not have been detected with this type of screening. Then for the CRC analysis, we performed Cox proportional hazards regression to obtain hazard ratios and confidence intervals, and we used the same referent group that we talked about for adenoma analysis. And then to look at results by anatomic location, we performed joint Cox regression models, looking again at the different parts of the colon and the rectum. So getting into some of our results, this is our characteristics of our population. We had about 88,000 men and women who were part of our cohort to look at colorectal cancer. Most of the participants were current drinkers, about 73%. And then compared to current drinkers with the lowest lifetime average drinking, which was less than 1 drink per week, current drinkers in the highest lifetime drinking category, which was greater than or equal to 14 drinks per week, were more likely to be male, non-Hispanic white, current smokers, and overweight. They were also more likely to use NSAIDs or non-steroidal inflammatory medications like ibuprofen and aspirin. They were more likely to use NSAIDs regularly and eat more red meat. They were less likely to be college educated, to report a family history of colon cancer, or use hormone replacement therapy. And they tended to consume less calcium, less fiber, and less folate. And then when we looked separately at the participants for the adenoma analysis, it was very similar patterns. So let's get into the results. I know this table is a little bit busy, but I'll try to highlight for you the most important parts. So this is our results for looking at lifetime average alcohol drinking in colorectal adenoma or polyps. So we're showing on the left side of this table is overall adenoma. Then we look separately by adenoma severity, advanced or non-advanced. And we also look at location of the adenoma, rectal or distal. When we look at the highest, higher lifetime drinks per week, we did not see any associations with adenoma. But then when we go up here to former drinkers, we see that former drinkers had a lower risk of colorectal adenoma, particularly the non-advanced adenoma. So we see some benefit of cessation of drinking. Similarly, when we looked at lifetime alcohol patterns in colorectal adenoma, we saw here, so this table shows, again, the current drinking status, or the drinking status in terms of never, former, current, the frequency in terms of, was it, for the current drinkers, whether it was always light or below the dietary guidelines, occasionally moderate, occasionally heavy, or always moderate or heavy. And we can see that there was some evidence of lower risk here for the, sorry, I'll go back, here for the former drinkers. So again, similar to what we saw in this previous slide I showed you. But we didn't see a significant effect with higher drinking in adenoma. Now moving into the colorectal cancer results, this table shows the results for lifetime average alcohol drinking and CRC. So if you look at the lowest, the bottom row of the table, this is for the current drinkers with the highest lifetime average drinks per week. We see significantly higher risk of colorectal cancer overall for this highest group of drinkers compared to the lowest current drinkers. And particularly this association was observed for rectal cancer. And we did not see it as much for distal colon or proximal colon. And then when we look at the previous row on the table, which is the sort of moderate drinkers, we observed that there was a protective effect of drinking on colorectal cancer, which was specific to distal colon cancer shown here. So this finding we do want to interpret somewhat cautiously. We don't want to say that drinking is protective for colorectal cancer, but there is some evidence in the literature that sort of moderate levels of drinking may reduce inflammation and may have some benefits, but I think we're less sure of what's happening for the moderate drinking levels, so we want to interpret this cautiously. So then when we look at lifetime alcohol patterns in colorectal cancer, we see the main finding was that those who were always heavy, so the current drinkers who were always heavy, had a significantly higher risk of CRC compared to the current drinkers who were always light drinkers. So just to summarize some of the strengths and limitations of this work, we had a prospective study design. Among the strengths, we were able to, the fact that the participants reported on their alcohol before they developed illness reduces some risk of bias. We also had the ability to assess the adenoma and CRC within the same study based on the fact that we leveraged the data from a screening trial. We also had the ability to assess alcohol in several time periods. And then as far as limitations, I did not have a chance to show the results by sex. We did not see significant differences in results by sex, but we had limited statistical power because there were relatively smaller numbers of women. And then the generalizability of the results is somewhat limited because we had a predominantly non-Hispanic white population, which is the population that was enrolled in the PLCO study. So the conclusions from our study is that we found significantly higher CRC risk, especially rectal cancer, for current drinkers who had the highest lifetime average drinking of greater than or equal to 14 drinks per week. And also for those with consistent heavy drinking compared to consistent light drinking over adulthood. We did not observe significantly increased risk for colorectal adenoma with higher drinking, but we observed significantly lower risk of non-advanced adenoma among the former drinkers. So again, this suggests a potential benefit of quitting drinking on adenoma risk. We did not find significant differences by sex, but there were limited case numbers for women. As far as future directions, as I alluded to, future studies with larger numbers of women would be informative and also to look at more diverse populations. We also would like to further study the impact of reducing alcohol or alcohol cessation. So based on what we know in the literature, I wanted to talk a little, just briefly in the last minute here, what can we do to reduce the risk of CRC? So I wanted to really highlight the importance of screening, and you may know this, but the U.S. Preventive Services Task Force recently, in 2021, revised the recommendation for colorectal cancer screening to start younger at age 45 instead of age 50 for average risk individuals. And we recommend that you would talk to your doctor about what age you should start and the types of screening tests. There are different tests available. There's I think a lot of people know about the colonoscopy test, which is a medical procedure and comes with some risks like any procedure. But an advantage of doing that is that colonoscopy can not only detect, but also remove precancerous polyps or adenomas through the process. So that's an advantage of doing colonoscopy, but there's also a number of other tests that are less invasive that can be used to screen for colorectal cancer. And I think the U.S. Preventive Services Task Force has not said that one test is better than another, and really, maybe any screening is better than no screening. So it's really important to stay on track with the screening schedule. And then the other things you can do is maintaining a healthy weight, regular exercise, avoiding smoking, and there's some dietary factors, like if you increase high fiber whole grain foods, increasing fruits and vegetables is beneficial, and reducing red meat intake. And then, as our discussion today, there may be benefits to limiting alcohol consumption as well. So with that, I would like to acknowledge our study team for the colorectal cancer work. The analyses were led by Caitlin O'Donnell, who was formerly at the NCI, now currently at Ohio State University. Dr. Erica Lawfield and I share senior authorship for this work. And then we also acknowledge our additional collaborators, Dr. Sonia Burnt and Dr. Wenyi Huang, who were at the NCI, Dr. Andrew Kuntzman from the IARC, International Agency for Research on Cancer, and Dr. Kenny Chudi Onugwaje, who's at the Center for Global Health at UPenn, and acknowledging our funding sources as well. So with that, I would like to thank you very much for your attention, and I'm happy to take any questions.
Thanks so much, Dr. Berry. So that was very interesting. And we have a few questions already that have come in. And so the way I'll do this is I'll ask the questions, but then if anyone has follow-up questions, please put them in the Q&A or in the chat, and definitely keep the questions coming. So we kind of have a pattern of questions, and that relates to the timing of alcohol consumption, particularly around binge drinking in high school and college, but then people who didn't drink into adulthood. So what do we know about sort of early age binge drinking and cancer risk?
So that's a great question. And we know, we know that there's been increasing early onset colorectal cancer and some other cancers, and whether patterns of binge drinking and younger ages could be contributing to that. We couldn't address that directly in our study because the ages of enrollment, we couldn't look at early onset cancer specifically based on the ages of enrollment in our study. Like I said, we did though have alcohol at different time periods. I don't know that we can conclusively say it's one particular time period that's driving it. We sort of looked at overall lifetime risk, and it's a little bit hard to separate out what is the effect of individual time periods because they're related to each other. So if someone drank, I mean, there are sometimes people like, as I showed in our data, we had some people who were former drinkers, but it's relatively smaller. A lot of people who were drinkers, like remained drinkers throughout their life. So it's a little bit hard to study the individual effect of separate time periods, but I think that that's really important and something that we do that warrants further study.
Perfect. Thanks. Now, what about the type of alcohol? So we have beer, we have wine, we have spirits. Were you able to look at that, or does the Surgeon General's report address that at all?
So in our study, we had collected data on different types of alcohol, but we combined them for our analysis. I think it's an interesting question, and perhaps worth looking at if there's different effects for the different types. I did not see in the Surgeon General's report separate description of effects for different types of alcohol, but I may not have read the entire, I might have missed some of that detail, but I think in general, the recommendations are based on alcohol in general and not on specific types. But I do think that's a good question and something we could perhaps look at in our data. Thank you.
Super. So we have a couple of questions around whether there are any interactions between either pathogenic variants or maybe polygenic risk score and alcohol and cancer risk.
That's a good question. In our data, we did not incorporate genetic data. However, the PLCO cohort that has genotyped a large percent of their participants. So that could be an interesting question to look at for the future. I would need to look up what's known from other studies, but I think that that's a good question. It's, again, another area for future research.
Perfect. All right, so another question is about underreporting of alcohol consumption by participants. And so can you address that potential either recall or reporting bias?
Yeah, great question. I think, well, with our particular study design, because we had a prospective cohort study and participants reported on their alcohol intake before they developed disease, we don't expect to see recall bias. We do expect there may be some underreporting of drinking just for because of social desirability bias, for example. But again, we don't think that that would vary depending on their future development of cancer, since when they answered the questions, it was before diagnosis.
Yeah, perfect. So we have another question about the fact that IARC has classified red and processed meat as a class 1 carcinogen, and whether or not in your study how you controlled for red meat intake, and if maybe there is just a relationship between red meat intake and alcohol consumption.
Question. I mean, there are, if you think about, I mean, obviously, if someone's drinking more alcohol, that's going to affect many other, it'll be related to many other lifestyle factors, right? So how do we tease this apart? Can we adjust for these other things? In the PLCO study, we had data on actually many different other factors, which I think is a strength. Because we had the dietary history questionnaire, we were able to look at things like red meat, processed meat, folate, fiber, dairy, and fruits and vegetables, and so we were able to consider a lot of different dietary factors. I do think that it's important to adjust for those variables as they'll be related to alcohol. It's a good question.
Um, yes, I mean, certainly it's tricky whether or not you have all the data that you need. I'll just throw in that, of course, MyCares, or the Michigan Cancer and Research on the Environment study, is a cohort study of 18 to 49-year-olds where we are collecting lifetime alcohol consumption. So, you know, in 10 years' time, probably, maybe 20, we'll be in a position to understand how alcohol consumption across the life course influences both early onset cancer as well as later cancer diagnoses. And I think that's one of the amazing things about the kind of newer generation cohorts is enrolling younger people. So of course we have to follow longer to observe cancers, but that's such a good thing. It's not that we want more cancers, but we're at least positioning ourselves to be able to answer some of those questions.
That's great. I know I've actually been thinking about what are the resources we can look at to address some of these questions and look at early onset, to be able to look at alcohol throughout adulthood and early onset colorectal cancer as well as later onset. And it sounds like the MI Cares is a great resource to do that. So that's really exciting.
Yeah, no, it really will position us to be able to answer these questions.
Yeah, in addition to colorectal cancer, we sort of talked a little bit about this, but there are other cancers have been showing increases early onset cancer for other types. So you could, look at many different types of cancer. I think that's great.
Yeah, no, it's good. And we are trying to do complementary studies where we enroll people with early onset cancers, and then we can compare them to the MyCares participants as a comparison group to try to get answers even sooner. So that's really cool work being led by Dr. Ellison Mondel, who I know you know, of course. So that's really great. So a couple of other interesting questions relate to whether or not some populations are more susceptible to the association between alcohol and cancer. You already talked about in your study that you weren't able to see differences between men and women. It looked like in the Surgeon General's report that maybe risk was a little higher for women with, I think it was 5 additional cancers per 100 compared to 3 for women compared to 3 for men. But what about other factors like family history of cancer? And this sort of comes back to also the question about genetics.
Yeah. I'm trying to remember if we did adjust for family history, but I don't think we separately stratified by family history. But I think bringing that in and or the genetics, I think would be really interesting. That in theory, you would, I mean, family history could be, like you say, a proxy, right, for genetic susceptibility. So that might be a first step you could take and see if there's a signal there. And then if you see something, you could then follow that up, bringing in the genetic data.
Yeah, I think that would be a very interesting step. Um, so we have a question about whether or not heavy drinkers should be screened for, let's say, colon cancer more frequently. Are there any data on that or recommendations?
Let me look quickly at the report because so I'm looking at the Surgeon General's report, and I think um, they talk about promoting the use of alcohol screenings. I think that, they want the clinicians to ask their patients about their alcohol consumption, and you know, they talked about how can we kind of intervene and maybe help reduce alcohol from in the clinical setting, and then referral to treatment. But that's more referral for alcohol. But um, I think that I don't know that we're quite at the point of changing recommendations based on for screening based on higher alcohol consumption. But I think that um, it's something that people should be aware of, that there's this link, and that I think, if you have more risk factors, it may want to lead you to for more screening. So again, there may not be official recommendations on this yet, but we may be moving in this direction.
Yeah, it's interesting because there's another question about whether people, heavy drinkers, should be screened at an earlier age. And I mean, we've already seen for colon cancer changing the age for starting from 50 to 45, as you mentioned. And there is a lot of work going on to do further stratification. Some of it already exists, of course, if you have a strong family history, those recommendations may be different, but there are definitely people doing a lot of modeling to see whether you could identify groups who should start screening even earlier or later. I mean, it sort of goes both ways. Maybe there are subsets of people, as we think more and more about precision prevention, that maybe don't need to be screened at 45. Right now the recommendations are quite generic. Do you have any insight into where that might be headed?
Well, that's a good question. I don't know that I have personal insight, but I totally agree with you that that's the direction we want to head, like this precision screening. Because if we can target screening to the higher risk individuals, that will be more effective, and will also spare people some screening who don't need it, right? So it's really, I think that's the way we want to go. And as we get more data on what are the risk factors, both lifestyle, environmental, but also genetic, and look and ideally put that together and better predict an individual's risk, that should inform when and when they start screening, and maybe how often they get screened. And so I do hope, I mean, I think we are moving in that direction.
Yeah, one of
Great point.
our colleagues here at Michigan, Dr. Jian, has done a fair amount of that modeling in colon cancer, and it's quite interesting. Of course, the uptake of precision prevention will be a different kind of discussion, because people are both excited by, but also probably a little bit nervous about, making these kinds of changes. So that'll be really interesting to watch. I think this is a very interesting question that I don't know if you can comment on, but one of the attendees has noted that people used to say that alcohol protected against heart disease. And is that true? And uh, given that information, how do you balance that with potential increased risk of cancer?
Yeah, it's really a challenging question. And even in our data, I showed you that we did observe some protection for colorectal cancer with that moderate drinking group, but I'm hesitant to make a recommendation based on that. But you're right. There's also data for in the heart disease space that there is some protective effect of kind of moderate alcohol drinking with respect to different cardiovascular outcomes. So then, yes, how do we balance that with the cancer risk? And generally, it's thought that higher drinking is associated with higher risk of cancer, that there's not necessarily a safe level. So I think that it's obviously then really challenging to take that and into actionable recommendations. I mean, I guess it seems like the effect of moderate drinking is a little less clear. We know, I mean, I think what we do know is that higher drinking, the highest groups have higher risk of colorectal cancer and different cancers. It's a little less certain what's happening in that middle tier. There may be some health benefits, but you have to acknowledge there could also be some risks. So it's it is definitely an area I think that we maybe need to do a little more work in clarifying what's going on with that moderate drinking group.
Yeah, I mean, I guess a way of potentially interpreting that is maybe people in that moderate uh, group maybe are having more broadly a healthier lifestyle, for example, and that's really what we're seeing. I think
Right.
could
So you're
be,
that maybe we didn't fully control for all those, and that's a good point. I think that could very well be the case. Did we control for all of those lifestyle factors that correlate with that moderate drinking?
yeah,
And
yeah.
it's hard to tease it all apart.
It is. It's really hard. And, ultimately, when we're thinking about actions that may be protective for one disease could increase risk for another disease. And so it's always a balance and trying to think through kind of the full scope. We think a lot about that for um, uh, ovarian cancer, which is my main answer, my main area. We know that the oral contraceptive pill cuts your risk of ovarian cancer in half, but we also know that while you're on the pill, you have a transient increase in your risk of breast cancer. So, we have to think about both of those and, and the kind of broader ideas around precision prevention. Maybe we're thinking, in the ovarian breast space that taking the pill at a younger age when the absolute risk of breast cancer is pretty low in the population, that you could get the benefit for ovarian cancer and then stop taking the pill when your risk of breast cancer has gone up. And
Hmm.
so this is very uh, complicated to factor in um, all of the different health impacts by uh, given kind of lifestyle choices. Um, yeah, so there's kind of a question about binge drinking. So is drinking one drink per day the same as drinking 7 drinks on one day? And so what does sort of the binge drinking literature look like?
Yeah, good question. And yeah, there's definitely a lot of interest in this, and we couldn't really look at that so well in our study, but I think it's a really good question that should be considered for future studies. So binge drinking, yeah, like drinking one a day is considered different than like if you had seven at one time, seven in one day, that's different than having one a day for 7 days. So I so binge drinking is kind of in a separate category, and um I would I would say that, so I think for women, I think it's defined as having four more drinks in one day. And for men, I believe it's a little bit higher, maybe six, if I'm speaking correctly. So, but I think, yeah, so it's not just, so it does sort of matter like how you, in terms, like we looked at how many drinks per week, right? But it does kind of matter how those drinks are happening throughout the week. Like, is it concentrated on certain days or is it spread out? But the U.S. dietary recommendation says women should have no more than one a day, and men should have no more than two a day, as a general dietary recommendation. And so in that case, you would not be in a binge drinking situation, and that's considered. I don't know. I don't want to say this is healthy, but it's sort of the way the guidelines stand now. But I think binge drinking. As more data becomes available, I think we'll know more, but I think there's a thought that that is more harmful to have so many drinks at one time.
Yeah. And so you're absolutely right that the definition for binge drinking for men and women is different. And in our My Cares questionnaire, we ask about alcohol consumption generally, and then we have very specific questions around binge drinking because that is definitely an area where we want to be able to shed light because there isn't as much data as we would like. All right,
I'm curious. Oh, I just wanted to say for binge drinking, and I'll be curious to talk to you more about your data. It sounds like a great resource, but I'm wondering if you're seeing how the patterns of binge drinking are changing over time. So I know like it's sort of generational. We've seen these different patterns, and I think that would be really exciting to show or to look at whether the generational differences in binge drinking could contribute to some of these patterns in cancer that we're now seeing. But I'm curious, like as you get more data and as time goes on, like are we seeing reduced binge drinking over time, or it seemed like it was increasing, but are we now decreasing again? And then what's going to be the impact of that on cancer and other health outcomes?
Yeah, because there has been a lot of talk around kind of younger people drinking less now than they did, let's say, in the 80s when I was growing up, for example. So it will be really interesting to look across sort of both decades or age at enrollment, but then also kind of decades over time. So that will be very interesting. All right, so one of our questions is, are there resources available to help reduce alcohol consumption? So we will pull those resources together in Michigan and post that on our website in a follow-up informational pamphlet. So we'll put that on our website and then push that out to the people who registered for the webinar. So that please watch your email for that. And then so there's someone in the chat commenting on how agreeing that it's possible that heavy drinkers may have other lifestyle behaviors that may also affect risk, like amount of exercise or dietary choices. So I know that you adjusted for those factors. I think obviously the question is always, are we able to completely control for those, or is there some leftover effects of those
there could very well, it's a good question. There could very well be leftover, residual confounding. I think as PLCO, it's nice that we have this dietary questionnaire. We have a lot of information that we can look at, but we also have it just to this, we don't necessarily know all of these factors over time. And I feel like it's the lifetime exposure to all these different things. And so we are somewhat limited that some of the data is just one time point only because people change their behaviors.
Right.
And then so you want to kind of account. I mean, it's a lot of data to wrap your mind around and to collect, but ideally you would have data on these different factors throughout the life course and then be able to account for that.
Yeah, I mean, so in my cares, we're taking a life course approach and asking, what people did in their teens. And, if someone joins when they're 40, what did you do in your 20s and your 30s? And then, of course, following through time and getting updated information. But all of that is, like a really heavy lift. And we'd like to thank the National Cancer Institute for letting us do that. And it is one of the challenges with a study like PLCO or many cohort studies where you only have what was happening at the baseline when people enrolled, and then not being able to capture what came before, oftentimes, and then what comes after. So
They do ask, I mean, in that particular study, they do ask some questions about, history of different behaviors or weight. So in a previous paper, we had looked at weight change over adulthood and colorectal adenoma. And we're able to look at weight at different, so this was, this participants reported at baseline what was their previous weight at different ages. So you can still get some information, I guess, before the questionnaire, which does help. But you may not have that for every factor. But in our study, we did find that weight change, increasing weight over adulthood was associated with higher adenoma. And then for those who lost weight, there was a benefit for those who were starting as an overweight or obese group. So it's not saying everyone should lose weight. It's if you're depending on where you're starting. But it was nice to be able to make use of some of that data based on their reporting, having asked the participants their past weight at different ages.
Yeah. Yeah. And I mean, I guess also super interesting about weight cycling. So people who are losing weight and then gaining weight and losing weight feels like the story of my life. All right. I know we're a little over time, so completely understand if people need to drop off, but we'll just get these last couple of questions in quickly. And two of them are very much related, and it's about the impact of other lifestyle factors and whether they're interacting with alcohol consumption, and then affecting cancer risk. So specifically about smoking and alcohol, and then potentially other lifestyle factors. So I'm not sure what the literature generally says about that, or if you've been able to look at that in your data.
Yeah, good question. We actually have not looked at interactions between smoking and alcohol consumption in our study, but that's a really good question, and maybe, that's something we could potentially look at. We do have some smoking data. And based on what I was showing earlier in the presentation, there are, some of when I was talking about the mechanisms that the alcohol can lead to cancer risk, the fact that like tobacco carcinogens can dissolve in alcohol. So if someone is drinking and smoking at the same time, you think there's definitely a way that there can be an interaction between those two things. So I think there's plausibility to look at that. I think it would be interesting. As far as other lifestyle factors, I mean, I think that's a good question. I can't necessarily speak to that based on what we've done, but I think, it's a good question, a big, broad question for future in terms of, I mean, because you're not exposed to one thing in isolation. So what is it, the combinations of factors, I think is an important thing to study.
Yeah, no, I think it's super interesting. And when we think about looking at multiple factors, there are two ways that we think about that. For the audience, we think about, do these things add up? So if I smoke and I drink, are these risk factors adding together to increase risk? But then we also think about a term that was used, interaction, are the combined effects more than the adding the risks together. And so those, I think, that's a lot of the work that we do when we're thinking about what is somebody's lifetime risk of disease, of a given disease. And so sounds like maybe Dr. Berry will take these questions back and take a look in the data again. And so the other question is curious about beer versus wine. And so I think what Dr. Berry was saying is that the Surgeon General's report is agnostic to type of alcohol, and that in your data as well, I think that you also combined sort of all types of
We did,
alcohol.
but we did have separate data, so thinking about that's something we could potentially look at separately. And we know, like when we think about when we talked about the cardiovascular, alcohol and cardiovascular health, I think that's more for wine that we see
Mhm.
that. So, maybe when you're choosing your type of alcohol, just think about, like maybe there's some benefit for wine, but there's less benefits for other things, and then balancing that again with the harms that we see.
Yeah, and also thinking about the recommendations and the size of a wine glass and the pour of a wine glass, because people are often surprised by what a serving of alcohol actually looks like. So
Very true.
I think we also have to think about that. All right, we'll do this last question, which is basically about retention in PLCO and whether you think there is any risk that people who dropped out were more likely to be heavy drinkers. So, some level of selective dropout. I mean, I think if that were true, then the results from your study are less than truth, if you will. But I guess a question is, are moderate drinkers who went on to get cancer more likely to drop out? And does that explain the protective effect? What do you think about that?
Yes, these are really great questions. So the question is more about if those who were moderate drinkers would be, if they were more likely to drop out.
Yeah, I mean, I think the question is sort of somewhat just asking about, is there differential dropout based on exposure, an
Hmm.
outcome, whether there's some selection bias creeping in.
Yeah, I would have to look at that in our data. I, I, let me see if I have some information. And it's something I can look at, after after the call. I don't believe that there was a large percent loss to follow-up, but I can look at that and also look at whether that differs by their alcohol status. Um, we also then there's also just maybe a separate issue, but then thinking about people who were in the former drinker group, like how did they um, were some of them changing their changing their alcohol because they were getting health effects from it. Like maybe they had high drinking before, and so like the former drinkers can be a mixed group.
Mhm.
So that's something else that we've been thinking about, and so I'm not sure. And initially I think we had included former drinkers in our referent group, but then we realized this is definitely a different group of people, and that should be looked at separately. But yeah, there's things about whether their drinking could have affected the amount that they stayed in the study, but also um, once let's say someone gets a screening and they find if an adenoma is detected, would that change their drinking? So like
Mhm.
there's these
Right.
things will affect each other. So that adds another layer of complication.
Yeah, yeah. I mean, it's interesting when you have a precursor lesion like that that's being
Right.
treated. Yeah, super
Yeah.
interesting. Okay, well, I'd again like to thank Dr. Berry for joining us today and giving such an interesting presentation and answering all the questions from the audience. Certainly feel free to email us at mycares if you have additional questions, and we can pass them on to Dr. Berry, or you can reach out to her directly. Thanks so much.
Thank you so much for having me, and really great questions to think about for the future. And I would love to talk to you more about your MI Cares study. It sounds fantastic.
Yeah, that'd be great. We'll enjoy that.
All right. Take care. Thank you so much.
Bye.